Okay, when we stopped our video before, we were talking about a jaw that was locked back by closed bite, and the upper anterior teeth were lapping over the lower anterior teeth, holding the jaw back, and how if you open the bite, the jaw just wanted to come forward. It wants to get out from under that. Now, I want to mention something about not putting pressure on your jaw, pushing it backwards. Like you shouldn't sit with your holding your head up by resting your chin on your hand or arm or book or whatever. That pushes it back. I've had people, in fact, a good friend of mine, one of my best friends, is an orthopedic surgeon, and his wife was having jaw joint problems, and I just talked to her about it, and sure enough, she was doing something where she slipped one way and had her fist on the pillar or something and laid her chin on that, and it was putting pressure all night while she was like that on the condyle on one side and putting a lot of pressure on that. So I told her to quit doing this and try to sleep with the pressure, have her head holding up and have her jaw that was just free so she could move her jaw around. Now the retrodiscal tissue, we've got this, the fossa looks like an S laying down like this, and the condyle is sitting in here, and you open your mouth, it slides out like this, and this strap goes with the condyle as it opens, and it kind of moves back as your condyle goes out here. And this strap is made out of that dense connective tissue, and it's extremely tough. It takes a tremendous pressure. When you bite with your front teeth, the muscles back there by the joint, and it takes a tremendous pressure. So the dense connective tissue in this strap has no blood vessels, at least in the pressure area, no blood vessels, no nerves in that, and it gets fed by this synovial fluid getting pushed up into this tissue. The synovial fluid is a fabulous material because it's the slickest thing known to man. We can't reproduce it. Now the condyle pushing against that tissue and pushing it up against the fossa forces this synovial fluid into this dense connective tissue. It carries food and oxygen to the tissue and also cleans it or takes the synovial fluid that's been used like that and cleans it, kind of like a set of kidneys or something. It's a fabulous joint, and there's no other joint in the body like it. So you don't want to abuse it. If you get in there and you get really extremely tense and you bite real hard on it and press the tissue too much, then it doesn't get fed properly and you have trouble with it. That's one thing. So stress, and there's many things go wrong with the joint just because of the way we do, the way we have a stressful life. That goes wrong with it. So anyway, we don't want to put any pressure on it to add to the trouble that the joint has. So if you just stay off of it if you can. Now I like to tell people to, when you're sleeping, just rest, make sure your head is holding up the weight and your jaw is kind of free to wiggle around. And that's good. You can just kind of tap it a little bit. Well, that really feeds the strap that comes across there and helps it. But when we used to do orthodontic surgery, you wired the jaws together after you got what you wanted there, And sometimes you'd leave them together for 6 weeks or something, a long time. And if during that period the condyle was jam up against the fossa with a little pressure, no synovial fluid could get to it to feed the disc, so the part of the disc would die in that. Now, people who have a distal slide, or you look at, most people do have a kind of a distal slide. In other words, you just relax your jaw and kind of open and close it with your head in a good normal head position. And as your teeth get close together, you will bite down and then you slide backwards, go distal to where your teeth fit together, and that's where you kind of chew with your jaw going toward the back. Now those people, some of them have tough joints and they have no problem, but others have a fit with it. And so I worked with a guy for years who did nothing but TMJ work, and he would get them comfortable on splints and reposition their jaw. Then he'd send them over to me, and I had to take them and get their teeth moved to where their teeth fit together in this acceptable jaw position that he had more or less set them in with his splints and everything. So this was the hard part about doing that, but we got pretty good at it, and I think we were able to pretty well succeed on every one of our TMJ cases, TMD cases, however you want to call it, and had pretty good results with that. Now, distal slides gave us the problem. Now, all my practice, I looked for somebody that had an anterior slide that had temporomandibular joint problems. And I never found anybody. Now that was just lucky, because people with an anterior slide, that's where they come together, and sometimes they're class 3-ish, and they'll get down and they'll slip their jaw toward the front to chew. And they'll have no TMJ problem when they were like that. And I never found anybody with it, even though they could have arthritis and they could have trauma and they might have stress and all these other things. But when they pull their jaw out that way, you had all kind of room for this retrodiscal tissue. Now, I went to work when I retired. I retired at 75, and I went over to work just a couple of years with my friend Dr. Mike Whirley, and I ended up staying there 12 years. And when I got to know Mike real well, we were out eating, and I hope Mike doesn't mind me telling this, but anyway, Mike would chew with his jaw and his lower jaw out in front of his upper teeth like this, and then he'd stop. Now he'd go back here and chew like this, and then he'd come out and chew this way. And I looked at him and watched him for a while eating like that. I said, Mike, what in the devil are you doing? And he said, well, my teeth fit together back here, but my jaw starts hurting in a little bit, and so I have to move my jaw forward, and I chew this way, which I can chew, but it's not as efficient, and it feels good to do that. I said, Mike, all we'd have to do is just move your upper jaw forward some. If we move it forward, then your bottom jaw can stay in this forward position all the time while your teeth fit together. And we did, and pretty well got that done, and Mike's still getting along with it, jaw like that. So keeping the jaw in this forward position helps. And a lot of your TMJ problems with people that are hurting, you can take them in and find out whether the jaw really wants to close, if it's relaxed. And I've done this with a whole audience of people. Just have them relax and hold their head in a normal head to shoulder relation they have, and just kind of close their eyes and let their jaw just open and close. But when they get close to their teeth, don't hit. And find out where their jaw wants to close. Now go ahead and touch your teeth and start to bite your teeth together and see, does your jaw move backward or move distal to get the teeth interdigitated. And most people will have some kind of a distal slide, which doesn't feel good. And if you put them in a splint, you try to put them in a splint where their jaw is feeling its best. It'll close to in that position. And you do that, and the vast majority of them stop having pain. And I've had them with real serious pain, and it hurt for years doing that. So this type of orthodontics gets pretty complicated. But if you're doing orthodontics and you aren't paying attention to the joint up here, that is not right. You really should examine everybody that you work on. It doesn't matter whether you're doing orthodontics or doing crown and bridge or whatever you're doing. If somebody's got a jaw joint that's giving them trouble, then you need to kind of learn how to deal with their temporomandibular joint. And then you need to fix their orthodontics and the joint at the same time, or normally we go in, if it's very bad, we'll do the joint problem and straighten it up and then come back and do the orthodontics. So if you've got a disc off, and it'll get in front of the condyle out here, and you don't put it back or get it back or try to get it back, it gets pretty complicated with the orthodontic. Yeah. The thought came to me this morning about Anquilose teeth. There's a good many Anquilose teeth, not as many maybe as you run into, but they've kind of lost their attachment and they've actually grown to the tissue, and those teeth are very difficult to move. In fact, you can move the tooth if you can move the whole bony structure that the tooth's in. But sometimes you can't do that, and you need to move this ankylose tooth. And I had several impacted cuspids that I worked with through the years. They would be ankylose. So I'd send them to the oral surgeon and I'd tell him, I want you to luxate this tooth. In other words, he'd go up in there with an elevator and just actually loosen the tooth a little bit like he was fixing to extract it. Well, that breaks the attachment that is grown in there that's not normal. And then you have to speed up this thing. And so you get him back in and you hook that tooth up just as quick as you can and start pulling on it, but don't pull too hard. If he luxated it too much, you'll end up, you put stress on it to move it down or pressure, you end up pulling the tooth, you see. So you have to pull on it a little bit. And I have taken many ankylose teeth and had them broken loose or luxated, and then got them going and just kept moving them until I got them to the place they wanted. They may have reattached on that. All right, the last thing I want to talk about this afternoon is the basal bone. Now on your jaw, you've got alveolar bone, which is on the top of your bottom jaw, or the bottom part of your upper jaw. And the alveolar bone is what holds the teeth. The teeth are in the alveolar bone. Now, if you move the alveolar bone over to one side or to expand it, which you can do, and we do all the time, then the basal bone is supporting the alveolar bone at a kind of an angle, which is not the most efficient way for it to be. So you've moved the alveolar bone over here. So this basal bone is now functioning, holding that at an angle. Now, the body works out the most efficient way for this bone to do. So the body will actually move the basal bone to where it supports the alveolar bone in the most efficient way. But this takes, I don't know, it'd be different on everybody, I assume, but it takes a few months or even longer for the basal bone to move in place, where it supports the weight on it in the most efficient. There are a lot of things other than this that we as general dentists, pedodontists, or pediatric dentists, and just the general public needs to look at these videos